This is a brief talk about the Bow-Hunter syndrome, or the name given to the constellation of symptoms, predominantly dizziness, that result from the dynamic occlusion of either of the vertebral arteries. The references for all the images used in this talk are either mentioned at the bottom of each slide or on the last slide. Let's dive deep into the pathophysiology first. The vertebral arteries are paired arteries arising from the respective subclavian artery, ascending in the neck and then making a sharp loop around the second cervical vertebrae, or the axis. This is how they provide blood supply to the occipital lobes, the posterior fossa, as well as the spinal cord. The vertebral artery is especially prone to compression, mechanical compression, along the first and second cervical vertebrae, although compression can occur anywhere along the arterial course. In Bow-Hunter syndrome, head rotation to more than 30 to 45 degrees to either side causes the transverse process of a cervical vertebrae to mechanically compress the vertebral artery, reduce blood flow, and cause symptoms. The analogy of the coronary arteries luminal occlusion is given just to give you a visual image of what the narrowed lumen looks like and why it could lead to reduced blood flow. In Bow-Hunter syndrome, this mechanical compression could be related to osteophytes, a reason why the condition is often seen in conjunction with cervical spondylosis. The protruding osteophyte causes the vertebral artery to experience a shear stress as it courses over it, making it more prone to getting dynamically occluded during head rotation. The other reason could be atlantoaxial instability. Imagine that the yellow block is the skull and the two gray blocks represent the first and the second cervical vertebrae, or the atlas and the axis, respectively. Whenever the head rotates, neck rotation accompanies it. Normally, both the cervical vertebrae move more or less together. However, in cases where one cervical vertebrae is moving more than the other one, the vertebral artery again will experience shear stress, making it more prone to dynamic occlusion, creating symptoms of dizziness as seen in Bow-Hunter syndrome. In Bow-Hunter syndrome, this The other factors contributing to the dynamic occlusion of the vertebral artery include the hypertrophy of the atlanto-occipital membrane, this thing, or the hypertrophy of the paravertebral muscle fascial bands, cervical disc herniation, chiropractic manipulation, surgical positioning, or certain kinds of sports and physical activities. A look at this pie chart will reveal that the commonest presenting complaints of the Bow-Hunter syndrome include vertigo, syncope, and lightheadedness, all of which can be classified under the common bucket of dizziness. Hence, the schema from the website clinicalproblemsolvers.com that highlights the clinical approach to dizziness serves as a good basis for developing greater understanding about the Bow-Hunter syndrome. The schema is based on the 4Ts. The first T is of triage, or ensuring the patient's hemodynamic stability by looking at the vitals. Once that is ascertained, you move on to the second T of timing. That is exploring whether the vertiginous episodes are acute and persistent or more episodic in nature with periods of normalcy in between. This is also a good time to clarify with the patient what exactly they mean by dizziness. Do they mean they get a sense that the room is spinning around them, in which case we would think more of cardiovascular causes? Or do they get the sense that their own head is spinning? The illusion of the head spinning is termed vertigo and points to more neurological causes. Once it is ascertained that we are dealing with vertigo in a patient with dizziness, we start to move towards the third T in our list of 4Ts, which is triggers. Moving on to the triggers, ask the patient if specific movements of the head bring on the vertiginous episode. For instance, rotating the head only to the right triggers the symptoms, or maybe the symptoms come on when the patient tilts the head back slightly to take a break from a prolonged period of reading, which would have involved bending the neck slightly forward. It's also important to explore whether that particular head movement brings on the vertiginous episode or does it worsen an episode that had already started. When a specific type of head movement triggers the episode of vertigo, it would fall under the category of positional triggered vertigo. And the next step would be to come to the part in the schema where we explore whether it's benign or central paroxysmal positional vertigo. This is where we come to the fourth T, or targeted examination, and conduct the Dix-Hallpike maneuver to see if it is benign paroxysmal positional vertigo. The Dix-Hallpike maneuver is the standard clinical test for benign paroxysmal positional vertigo, or BPPV. The classic rotatory nystagmus with latency and limited time period is pathognomonic. However, a negative Dix-Hallpike only indicates that active canalithiasis is not present at the time, and one still needs to rule out the more dangerous central paroxysmal positional vertigo, or CPPV. Central vertigo will often mimic the benign form, will have negative Dix-Hallpike, will be triggered by positional changes of the head, movement of the head in specific directions, and will not respond to Epley's maneuver of canalith depositioning. Bow-Hunter syndrome is one cause of central paroxysmal positional vertigo. That's a good way to think about it. A quick point needs to be made here about the HINTS exam. The HINTS exam has no role in the targeted examination of either benign paroxysmal positional vertigo or central paroxysmal positional vertigo. The HINS exam, that is the head impulse test, direction of nystagmus, and test of skew deviation, is only utilized in case of an acutely actively vertiginous patient when the patient is experiencing continuous vertigo. Moving on to more discussion about the Bow-Hunter syndrome. The condition was thus named because the first such case was reported in an avid hunter who presented with symptoms of acute inferior cerebellar artery syndrome after a session of archery practice. When the cerebral angiography was done, the person's right vertebral artery was found to be in a spasm. The case was first described, as you can see in the slide, by Dr. Bruce Farrell Sorensen, and the report was first published in 1978. Since then, many cases with similar presentations have been labeled Bow-Hunter syndrome, regardless of whether the patient has ever practiced archery or not. Let's scroll through a few more cases of Bow-Hunter syndrome. This is one where a 41-year-old man presented with symptoms only upon leftward rotation of the head. You can see the stenosis occurring dynamically when the head is rotated in that particular direction. All of this is by digital subtraction angiography. Another case where it was reported in a 53-year-old person, again with rotation to the left. In this case, it was a 62-year-old person, and here, this was a case of a very young girl, only of 13 years of age. Now, if we look back to our original schema, we will find that the classification of vertebro-basilar transient ischemic attack, TIA, is not included with the positional triggered bucket, positional triggered episodes of vertigo. However, in the case of the 13-year-old girl who presented with paralysis of the left side, transient visual disturbances, and was eventually found to have a thalamic infarct, that line between vertebro-basilar TIA and other kind, the Bow-Hunter syndrome, which we are clubbing with central vertigo, can start to blur. As we just mentioned, many typical and atypical cases of Bow-Hunter syndrome have been described in literature, and an additional hypothesis that is being explored in connection with the pathophysiology is that when the vertebral artery is mechanically compressed, blood flow slows down, a thrombus formation results, which eventually embolizes and causes symptoms. Excuse me. Finally, let's move on to the diagnostic and treatment modalities. The gold standard for diagnosis is dynamic cerebral angiography, which allows the reproduction of symptoms with head rotation greater than 30 to 45 degrees. There are no clear guidelines about the management. Whether the management is to be done surgically or conservatively varies from case to case. However, in every case, it is extremely essential to make the patient aware and ensure that they stay away from misinformation and harmful practices, #prolotherapy. This brings us to the end of our talk. Here is the references slide. On the title slide, you saw a picture of an archer with a bow, and that picture was taken from the website of the Missouri Department of Conservation. And the picture of the dynamic stenosis by digital subtraction angiography was taken from the website of Cleveland Clinic. The majority of this narrative has been guided by a 2017 article that appeared in the American Journal of Medicine by Dr. Paul Burgel. Thank you for watching.